Yes, sir, we are live now.
Good evening, everyone. I am Dr. Amit Gupta, Joint Secretary of Diabetes India, and I welcome you on behalf of the entire team of Diabetes India, our President, Dr. S.R. Ravind, our Secretary, Dr. Bansi Sabu, and Dr. Sanjay Reddy, who is currently the Treasurer of the Diabetes India. And it is a great pleasure for me to welcome our esteemed speakers as well as the panelists and the moderator. So we have today with us Dr. Antonio, Dr. Julia Mother, Dr. Ram Kumar, and as you know that this is a day 3 learning session. Our next team, can you mute yourself, please? Yes. So as you know, this is the day 3 from the learnings from the ESD. ESD meeting was also of the 5 days meeting, and our learnings from the ESD is also scheduled for 5 days, and this is the day 3. And today it's really a pleasure for us to have this esteemed panel and faculty. They are going to bring you one of the best sessions or one of the best talks which they presented at the ESD, and I am sure it is going to be of great value. With this, I would like to invite Dr. Ram Kumar, who is going to be the moderator for today's session. And Dr. Ram Kumar is a well-known, renowned diabetologist, and he is known for his laughter as well as he is also known for his some magical skills. And welcome, Dr. Ram Kumar, and over to you. And now you can proceed with the session.
Okay. Good evening, everyone. Thank you, Amit ji and Bansi ji, for giving me this opportunity and Diabetes India. I was at EASD 2024. It was amazing program. And today we are going to talk about automated insulin delivery systems. That is the first topic. And second one is NAFLD, or that is a common problem in diabetics. And as you know, in India also, we have some type 1 diabetics. We mostly focus on type 2 because that is the major issue for us. But all of us see number of type 1 diabetics, where I feel that we are not giving adequate care because of so many problems, socio-economic causes, or so many things, or financial burdens. So what we will discuss is how to give the best possible treatment to the type 1 with automated insulin delivery. As you know, everyone will say that, oh, they're expensive. But when I discussed with these people who are treating type 1 diabetics, if you have some determination, we can also get them these devices. And today I searched this, and Dr. Mohan's study showed that there are 2 people in his clinic or in his hospital who lived more than 70 years with type 1 diabetics. And I also met Catherine Ham, 75 years with type 1 diabetes in American Diabetes Association. She was awarded Jocelyn Medal. So people are living longer, even with the basic needs. Catherine told us she used to sharpen her needles, boil the syringes with glass syringes. And from there, a lot of improvement is there in type 1 diabetes. So type 1 diabetes, I to know how we changed from animal insulins to human insulins and better analogs. So today I invite the first speaker. Can you show the slide, please? I met her in EASD in our Diabetes India meetings. So she will be explaining us about automated insulin delivery systems, how to choose the suitable one for each person. Madam Julia Madder, please.
Julia, unmute.
Sorry. So thank you very much for the kind introduction, and you already said one relevant point. So how can we really make lives easier for people with type 1 diabetes? So today I'd like to talk to you about how we started off with automated insulin delivery systems, what is currently on the market, and how can we then make good decisions. Here are my disclosures. And what have we seen in the past 20 years or so is that over time, from a simple insulin pump, the more and more integration and automation we became, and the less and less user input was required. So currently we do have hybrid closed loop systems where for the most systems, still a meal bolus might be beneficial. But of course, we are also looking into options of fully automated closed loop systems where not even meal boluses are required. As we all know, bolus timing, bolus dosing is still a hassle for many people. So in the real world, what have we seen? That also not in RCTs, but also in the real world, automated insulin delivery is investigated, and that's a study of 70,000 people in the US who were treated with an Omnipod 5 system, and all across the different age groups. So from the toddlers to the over 70 years olds, we can see that they achieve in real world nearly 70% of time in range. So I think that's quite convincing if we look into the recommendations from the current consensus, how diabetes goals should be achieved. And then when looking specifically into the people who switched from a previous generation Omnipod to the novel generation Omnipod with the automation, we again see that average of time in range is shifted from roughly 60% to 70% for young ones as well as for adults with type 1 diabetes. At the same time, we see that the time below range is reduced. So we have not only the benefit of optimizing glycemic control, but also reducing hypoglycemia. How have we looked into automated insulin delivery? So for example, in the population of small children, there was always the challenge, can we do automation of insulin dosing with regular insulins without dilution? And we performed a small study together with the team of Roman Hovorka and the team of Luxembourg University, and there we saw that even without diluting, we can achieve similar glycemic control without putting children at risk of hypoglycemia. Then another population of interest is, of course, people who are older, because maybe they might not be as tech savvy and might have difficulties in using their technology to manage diabetes. And what could we see here? Again, similar picture, especially overnight, the band gets smaller and we have less variation, more variation during daytime, but again, compared to the sensor augmented pump, less variability throughout the day. And interestingly, and I want to put your views here, the older group, they managed to get a good time in range already on automatization on sensor augmented pump therapy without automatization. So they are doing a good job and not being afraid of using technology at older age. Then there was a study performed in the UK again, where they looked into the YPSO pump. And of note, of course, this is a more closer target range of 63 to 140, the pregnancy target range. And again, here we could observe that more people achieved that or nearly achieved the target with closed loop compared to standard care. And what have we otherwise noted? Of course, there were some hypoglycemic events, but not very different between the two groups. Then an interesting aspect, AID during Ramadan. Can AID also work if people are fasting and are fasting maybe over day, but then having a feast each night? So in the period before Ramadan, we saw a very good performance of AID, again, meeting the targets overall, slightly worse performance at night. During Ramadan, as said before, of course, the feast is during the night, so that's probably challenging a bit more achieving the treatment targets. But during day, during fasting, people nearly achieved 80% of time in range without having risk of hypoglycemia. And the post-Ramadan period was again very comparable to the pre-Ramadan period. So transitioning between the three periods seemed to be working. When we then look into areas with simplified carb counting, what can we observe here? Also here, people were randomized to an intervention, small sample size of youths with type 1 diabetes. And they were either using a fixed protocol or a flex protocol with the system. And the ones who are doing the flex protocol, so where they did not have to do the carb counting in detail, achieved more time in range compared to the ones who had to do the task of carb counting. So again, we can say simplified carb counting works in type 1 diabetes. And I think that's really a good news for us, because carb counting is one of the biggest challenges that we still face. And the more automation we can get here, the better it's going to be. Then another group of people are hospitalized people with type 2 diabetes, and they have, of course, the challenge that in the hospital diabetes management might be altered due to infections, due to interfering factors. And those people were insulin treated, but not treated with AID upfront. And what can we see here? Here we see the glucose curves again of the people on the automated insulin delivery device in red. Again, at night, very good control. During daytime, higher variability, but still a more narrow band compared to the blue one in open loop, without increasing the risk again of hypoglycemia, and at the same time reducing hyperglycemia. In the contrast to the more stable glucose profiles, we observed more flexibility in insulin dosing. And because, of course, the insulin dose could not be tracked that detailed in the manually administered over the day, we only have here displayed the insulin dose over the day, which is highly flexible. But compared to both groups, the one on a control intervention had even a slightly higher insulin dose without achieving a better control. Another study looked into the Omnipod, and I think automation and also continuous glucose monitoring gained importance specifically during the COVID pandemic. And here people were put on an Omnipod system. And again, over time, we can see people achieved good time in range without increasing hypoglycemia. So that sensor was considered an erroneous reading where we had slightly higher rates of hypoglycemia. For type 2 diabetes, there is still a lot of research ongoing, because of course we do know we have modern therapeutics next to insulin that can be started up front. And the jury is probably still out for people with type 2 diabetes if AID is the most beneficial way to treat. But the 5 randomized controlled trials that we could find showed an improvement in time in range, and at the same time reduction in hypoglycemia, and did not result in an increase in insulin dosing. Also, Danish data are very supportive of this. So here we can see that people, the more optimization is used, so from MDI versus pump therapy without sensor connection to sensor augmented pump therapy to automated insulin delivery, the more automatization we get, the more time and range we get without increasing again hypoglycemia. And I bring to you now some data about different systems that we currently do have in Europe. I do know that in India, as far as I know from my last visit in May, you mostly use the MiniMed 780 system. What differences can we see maybe for other systems? So for example, one system definitely has a pregnancy variant with a dedicated target range. It also has the approval of the most variety of insulins, but otherwise the systems are relatively comparable. Maybe of importance with one of the systems, we are flexible in using a different sensor, but also Medtronic opened up in recent weeks, and we hear positive news that maybe in the future people can use the 780G with a different sensor. Again, what might be different? So we have different types of bolus deliveries. We have different temporary targets, but important, if we put in the temporary target at the MiniMed 780G, you lose the auto mode function. So you do not have any autocorrection. So it's not maybe the wisest selection to go for a higher target over a longer period of time, because then you lose the correction. So maybe it's smarter to stick with one of the three predefined target ranges when you want to achieve optimal control. Other versions in the future might be mobile phone driven. So there is Tidepool that has already achieved FDA approval, and the system that is developed by people in the UAE, where we hope to start a study later this year that's also based on a mobile phone. One of the important factors is, of course, interoperability, because what else would you want in the clinic than having access to the full data? And also for the person with diabetes, it's optimal if they have access to different types of technology. So if they can put the system together at their likings. But that's still one of the dreams that we have that is not yet completely fulfilled. An alternative still could be commercial systems, still could be the do-it-yourself automated insulin delivery systems, where people have to be at least a little bit skilled in developing their software tool, but it's not that you need to be a rocket scientist to be able to do so. So it's routine people who are having some literacy on a computer and a mobile phone who can do that, and they then can really customize the system to their needs. I'm not so sure if that community in the future is going to increase again, because now that we have more systems available with more flexibility, maybe people would not want to go down that road anymore. But the Night Scout community kicked off that initiative and is still there for people who are interested in doing so, and gives them enough support. And one consensus statement is also dealing with it, especially with the legal aspects. How can the healthcare professionals support people with diabetes with the wish to use automated insulin delivery systems that they use in an open source manner? So we looked into our Austrian population, again, not a big group, but the ones who did automated insulin delivery using an open loop system, an automated system using open source algorithms, achieved more time in range compared to the commercial system. Of note, of course, this was the 670G system that was maybe not as optimal as the system that we nowadays can use. And of course, we can say that probably the ones who used open source technology are maybe the ones interested more in technology and their diabetes as such. But also of importance, it worked throughout the age ranges. So we had pediatric groups, we had young adults, and we had adults above the age of 26. And in all three groups, we achieved superior control compared to the commercial system. So when it comes to the selection of the AID system, usually what I do, I have people look at the system so that they can have a look what is available in their country, how does it feel like, what is the combination that they can use, what's up for them within the system. Then usually they already have looked it up on social media and on different platforms where they also might receive recommendations. And then, of course, when I asked people with diabetes during one of our patient events, they provided the feedback. For them, it's important to be able to use it during sports. It might be important to become a patch pump. Tubing is important. For some, the age limit, so that was mostly the parents of kids with diabetes, and also if there are different bolus types that can be used. So the selection of the AID system should be patient-centered or person-centered. So because the person is living with the device 365, and we are just dealing with it during in-clinic visits. So as a wrap-up, there are currently various commercial AID systems on the market. New developments and startups can be expected. The correct handling of the system is still key, and the carb content and knowledge can help to improve the outcome. If the system doesn't work, look into the easy factors, if infusion set changes are performed, if the bolus timing is optimal. It works for adults, children, adolescents, in pregnant women, and also older people, as well as type 2 diabetes. The selection of the system should, of course, be according to the user's needs and preferences, and interoperability is still one of the big challenges. With that, I'd like to thank you for your attention, and I'm happy to take questions during the panel discussion.
Thank you, madam. You explained very nicely about AIDs and the various types available, and where we have to use particular system. And we will have more discussion during the panel discussion. And I'm inviting Dr. Padmasri Shashank Joshi to talk about NEFLD.
I think, Ram, there is a change in the program, and
Okay.
Dr. Antonia will be lecturing now. Dr.
Okay.
Antonia will be discussing on, I think, obesity and GLP-1 based therapies and update.
Okay, very good.
So I also recently saw there is a change in the program, and the topic name for Dr. Antonia. Antonia is a very close friend of all of us. Weight variability, a challenge in CVD prevention, also in the era of GLP-1 receptor agonist based therapies.
Very good.
We are very often quote Antonio whenever we discuss about glucose variability. So in all our lectures, we include his slides. Yeah. Thank you. Welcome to India.
Good evening, everyone.
Yeah, Purvi, hello, good evening.
Hello, good evening, sir.
Yeah, good evening.
Good to see you, Dr. Antonio.
I think that the screen should be closed because I'm not able to share. Okay, now it's okay.
Yeah, it's okay now. Yeah.
Okay, it's fine. Yes. So, good evening, everybody, and thank you for taking me again, even virtually in India. I'm visiting very often this beautiful country. So, my topic at EASD, in the context of a symposium organized by the Diabetes and Cardiovascular Disease, which is a study group of the EASD, was to share the new concept that the weight variability is really today a challenge in cardiovascular disease prevention, and what could be the role of GLP-1 receptor agonist therapies in this context. These are my conflict of interest. You know that some years ago, the very well-known trial addressing the possibility to reduce cardiovascular risk in people with diabetes, just lowering the weight, failed to confirm this hypothesis. So why was really successful Mr. Fit trial in lowering weight, not using any not using drugs? The primary outcome of prevention cardiovascular disease was not achieved. Later, let's say this year, it has been shown that cardiovascular disease can be prevented, but only in long term, but only if people are keeping the weight reduction. So in other words, it's not enough to reduce the weight. What seems to be more important is to keep the weight stable over time. But the reality is quite different. Very often, people affording a diet are able to reduce the weight, but very often the weight is regained, and this is very typical in the diet approach for weight control. What I will share with you this evening is that to look at the association between body weight variability and cardiovascular disease in people with type 1 and type 2 diabetes, but also without diabetes. The impact of body weight variability on microvascular disease, on other health outcomes, the possible molecular mechanism, and finally, which can be the strategies to face this kind of problem. First of all, let's look at the body weight variability cardiovascular disease in type 1, type 2 diabetes, and in non-people not diabetes. It's amazing to remember that the first demonstration that a weight variability is an independent risk factor for cardiovascular disease emerged almost 30 years ago from the Framingham Heart Study. This long-term epidemiological study showed that body weight variability in time in people not having, let's say, diabetes, but in a normal, let's say, the general population, was accompanied by a high risk for cardiovascular events. And this was called as a yo-yo effect, remembering the game, which maybe many of us were playing when we were young. We were able to confirm using the Swedish Diabetes Registry, which is an interesting database because it includes all the people of Sweden, which who are followed for years. So in cooperation with this registry, we were able to confirm that the body weight variability is associated with high risk for cardiovascular disease in people with type 2 diabetes. And this has been also confirmed in a recent paper we published, but as a post-hoc analysis of several trials and one real-world evidence. The trials included in this study were the Harmony, the Rewind, the EMPA-REG outcome, and the TIE-side bioresource. And in all the studies, excluding the EMPA-REG outcome, and we don't know why, the body weight variability was strongly associated with high risk for cardiovascular events in diabetes. So, epidemiological evidence, post-trials, post-hoc analysis of trials confirmed this. But what about the body weight variability and microvascular complications in type 2 diabetes? You see in this study that body weight variability is associated with the high risk of neuropathy. But while evidence is showing that the association between body weight variability and neuropathy, also with nephropathy, can be found, this kind of association is not reported for retinopathy. Why? Nobody knows. Meaning that we need maybe further studies to understand why the retina is protected, or maybe more large numbers to confirm that body weight variability is also a risk factor for retinopathy. Meanwhile, we have also evidence that body weight variability is a very important risk factor for the onset of a new diabetes. In this study, you see here that there is an association between this meta-analysis, you see that a body weight variability predicts high risk of developing type 2 diabetes. But why the body weight variability can be considered so dangerous. There are several hypotheses unified in what we published severally, some just last year. With cycling as a target the adipose tissue. You know, particularly in adults, the adipose tissue, when the weight increases, these cells increase the size. When the weight is reduced, the size of the adipocyte is reduced because there are no new cells, no new adipocytes generated. And this, according to several evidence occurs, is enough to promote an increase of some cytokines expression and release like IL-6 and TNF-alpha, which in turn produce immune cells recruitment, which in turn also generate inflammation, both in terms of local and systemic, which is the so-called low-grade inflammation. And you know, low-grade inflammation is the background of several diseases, but particularly of cardiovascular disease. What can we do to limit the effect of body weight variability? Why and how? First of all, let's put the body weight variability in a more comprehensive context. There is the variability of several risk factors which is involved in cardiovascular risk, increased vascular risk in diabetes. Not only weight variability is a risk factor, but we learned that the glucose variability, blood pressure variability, uric acid variability, lipid variability, all are linked to higher risk of cardiovascular disease. What happens that in the same person, you may have not only that one risk factors can go up and down, of course, because you can have a variability of the weight, but at the same time, a variability of glycemia, variability of blood pressure, variability of lipids. And we, again, in cooperation with the Swedish Diabetes Registry, we were looking at the ranking of the variability of these different risk factors in people who at the beginning were introduced in this study not having complications, particularly not having cardiovascular complications. And we found that body weight variability emerged as the most important risk factor over in the terms of ranking. You see here that the fourth most important was body weight variability. Then the second step was when body weight variability was associated with the systolic blood pressure variability. And after, when systolic variability was also producing high risk, but then when weight variability in the ranking was associated with A1C variability. So what is the most important message is that body weight variability is emerging as the most important risk factor compared to the variability of the other risk factors, which can be understood if you think that the body weight is controlling the glycemic control, blood pressure control, lipid control. So it's not surprising that body weight is a variability is emerging as the most important risk factor compared to the other risk factors. Of course, this kind of evaluation was corrected for the baseline value of all the risk factors. What can we do for this issue? I think that is well known that the property of weight reduction is different between the different drugs we use for diabetes treatment. And that recently the most powerful was emerging, GLP-1 receptor agonists were emerging as the most powerful therapy to lose weight, and not only in people with diabetes, but also in people without diabetes. And there is an issue because there is no doubt today is very cool. I think everybody knows that, for example, the two most used drugs for weight reduction, semaglutide and tirzepatide in several countries, are really effective in significantly reduce body weight. The issue is that when you stop, there is a regain of weight. You see, for example, for the step 1 trial, looking at the extension of this trial, people were really regaining weight. So stopping the treatment, the majority of the people were regaining weight. And this is true also for semaglutide, for tirzepatide. You see here, people who were continuing the treatment were reaching almost a steady state, so no more weight reduction, but keeping the weight reduction, but who was stopping the treatment was regaining weight. So I think this is a huge problem in the management of the weight variability, because on one side, we have the potential to control the weight, to reduce the weight. But when we stop these treatments, usually there is a regain of the weight, and this is not good at all. So probably we have to think about the new strategies in order to guarantee the long-term maintenance of the weight reduction. So in conclusion, obesity remains the more impactful factor for the onset of diabetes. Weight control with the pharmacological agents and lifestyle intervention is fundamental in preventing the development from prediabetes to over-diabetes. However, weight reduction by itself does not avoid the appearance of cardiovascular disease. Recently, weight variability has been reported as an independent risk factor for type 2 diabetes and cardiovascular disease. So it's clear that a new strategy for weight control in diabetes should aim to avoid weight oscillations and not only to reduce the weight. Thank you very much for your attention.
Thank you very much, sir. You explained this new concept of variability, like glycemic variability. This is very interesting, and we will have a discussion after this, and we will start the panel discussion. I invite Dr. Jyotidev Keshav, and all our panelists are here.
Dr. Purvi is also here. Oh, Mangesh is also here. Mangesh, welcome.
Mangesh and Purvi, please welcome, sir. So
good evening, everybody. Good evening.
Good evening. Good evening.
Yes, yes.
Sir, let me start with Jyotidev Keshavji, because you are our pump man. You are the person who introduced pumps to us, because I was there when you started this Meditronics course about pumps. And I want to know, how far is it feasible in India to get a pump to a type 1 diabetic, number one? And is there a lack of determination among us, or only financial problems? I want to ask you this question, whether you are able to provide more pumps for the type 1 diabetics.
Yeah, Ramkumar, it is a very relevant question. Dr. Julia Mather discussed about the possibilities using AAD. And the only AAD, as she said, the only AAD which is commercially available in India is 780G. And the question of Dr. Ramkumar is very specific. How can people afford? Yeah, in our state in Kerala, of course, the government is providing the AAD systems to people who are unaffordable, but that too only a very small subgroup. I would say that there are more than 4,000 subjects, and they can give it only to a couple of them. So it is not possible. But very important, what we have seen in charity programs, these devices, when we are giving it free of cost, we should make sure that the patients can use it properly. They should be empowered. And there is a checklist to see whether the patients can get trained on this, and the parents of young children can get trained on this, the basic education, the skills of using a device. So these are all very, very important. Even the best of the life-saving devices, if it is given to a wrong patient, it can even result in the death of the person. But in India, a recent trend, what we have seen is there are more than 150 people using DIY. Dr. Julia Mather also touched upon the do-it-yourself artificial pancreas, and these open source AD systems are also used by many people. And we doctors are not supposed to prescribe this. So we cannot support and we cannot prescribe. But according to the American Diabetes Association and other organizations, we should not discourage them from using this. So if somebody is using this, probably we need to support, and we need to have the basic knowledge on how to troubleshoot also. But again, these devices are not that freely available because we need older pumps for creating do-it-yourself. And nowadays, I have seen even some of the people, because the patients with diabetes, they can search the Google and find out the possibilities. So they are approaching the doctors to start on a DIY, which is a relatively cheaper device. So we are all probably having a similar challenge. And let me tell you honestly that recently, I was also forced to start a DIY on one of our patients. And we supported and we procured Mio Mio, we procured Riley Link and Orange Link Pro. And her timing range is now around 98% with the do-it-yourself, and the commercially available systems are only up to 75 or 80%. So sometimes it is even better. Anyway, I am not that an expert. Dr. Julia Mather will be the best person to comment on this. And she even presented the EASD on AccuCheck Solo micropump. And that is something we were expecting for the last 5 to 6 years. India doesn't have a patch pump. India has got multiple pumps, but only one AAD. So we are expecting the AccuCheck Solo micropump that Julia Mather presented. Along with the sensor, there is a new sensor also from the same Roche. So that is our dream. Our leader of leaders, Dr. Benshi, has just joined. He's there in the
Oh,
beginning.
I was there, you know. I was also there.
You were there throughout. I could see. And he has done a lot, and he is still doing a lot for our type 1 diabetes patients to bring all these technologies to our country. And probably Diabetes India, Dr. Benshi, our leaders like Dr. Mangesh of our associate physicians, all of our groups can probably try and answer to your question specifically on how we can manage to have all these expensive but life-saving devices for the common man. Thank you.
Sir, thank you. Thank you very much, sir. What I feel is, after attending EASD, there are so many better systems to make type 1 diabetics live better. So I think we need to work hard, and that's why I'm wearing this T-shirt, no excuses. So we have to work on the people with type 1 diabetics to do more, because they need more of our help. Dr. Bansi is doing a good job by organizing so many workshops. So I am asking Dr. Julia, what can we do in India for giving better control for type 1 diabetics? Dr. Julia, what is your idea?
So I think one of the biggest challenges you already tackled, that you try to take best care with the materials that you have, and I think you're doing an excellent job if we look into the publications that come out of India and where we see also the results that you obtain. And I'm not so familiar with your healthcare system. So I think one of the big challenges probably will always remain the funding. And I don't know, like government change and funding changes will be probably processes that take time. But I know Kerala, for example, could be like one of your flag posts within India where you see that a public funded healthcare system can work. So I think maybe using good examples and showing the results that you probably have there to advocate for a broader access to healthcare could maybe be one of the tasks that you have to take for the future. But I know it's a different path and long path that all of your Indian physicians probably need to take together with the people with diabetes to have a loud voice to really shout out for their needs.
Yes. Thank you, madam. I have
Ram, one question to Dr. Antonio. I mean, your weight variability and cardiovascular disease, this correlation, it is, everybody is very excited and listening your talk, and we all feel that how it can be having. Is it any possibility that, there are a lot of patients which we have a lot of weight variability. I mean, they are sometimes 90 kg and sometimes they have decreased to 70. So is there any possibility to join with you to give some data from India on a specific aspect, particularly weight variability in cardiovascular disease? I mean, something which is very interesting. I don't know from Southeast Asia any such paper has been there or not. So is there any possibility to collaborate with you for this particular project?
Of course, will be very interesting, and because there are data from Europe, our data from Asia, but like Korea, but not from India. You know that the phenotype of people living in India is very different in terms of where the fat is. So I think that if we can collect such data, would be even more interesting.
You can send us some sort of a Excel sheet, what type of data is required, and then we can get the local ethical committee. We can provide some data from India also.
If we are speaking about diabetes, it's not difficult because you need the weight over time. You need, of course, a follow-up of some years. Then you need the A1C, you need the lipids and blood pressure in order to correct for these values when you evaluate the impact of body weight variability. So technically is not different, not difficult, but so we can talk about this possibility maybe during my next trip to India, which will be next month.
That is, some of the data we can collect from API, from Diabetes India. We have our own Journal of Association Physician of India. Mangesh is the editor-in-chief, which is circulated. It is a physical copy with more than 20,000 doctors, physicians who get regularly once in a month. And since years, we are getting this journal very regularly. I mean, those who does not know about Antonio, he is the editor-in-chief of DRCP, Diabetes Research and Clinical Practice, one of the very high impactful journal. It's an official journal of International Diabetic Federation. So, I mean, it will be good that if we collect the data from India and we publish. And we also have our National Indian Obesity Society, which meeting is also coming. So, it's really very interesting that weight variability and cardiovascular disease.
Dr. Antonio, I want to ask you, what is exactly, how do you define weight variability? Means, is there any between this to this or anything? What 5 kgs, 10 kgs or something like that? How do you define weight variability?
So there are several, let's say, markers or measures, but the most used is the standard deviation over time. You have the measure of in time, and then you calculate the standard deviation. What is interesting is that what should be, in my opinion, explored more deeply is how much variability is dangerous. Because of course we discuss about the quartiles, for example. So this means that the higher variability is dangerous. But also we have to understand if this variability starting from 70 to 72 is the same when you start from 90 and you go to 95, for example. So there is a lot of work to do yet, but I think that the concept, the most important concept, is that the weight must be kept stable. This is the most important, because what is happening today is something that is not going in this direction, at least maybe in clinical practice, also you have the experience, that people are losing weight, particularly in some countries where these drugs are now available, but then you have to stop because you cannot, until now, I do not see people continuing for all the life these new drugs. Usually when you stop, there is a regain of the weight. So this is a complex situation today.
So now I am asking Dr.
So,
Mangesh. Right.
Dr.
Urvi.
Ram, if I can just intervene, I think
Yeah,
it's a very fantastic talks, both of you, Dr. Julia as well as Dr. Antonio. And this brings me to two questions actually. That often it happens that once people start losing weight, and then when they are below a certain level, their insurance won't cover, or the government, doesn't endorse further use of the GLP-1 drugs. So, does this really, do we have enough evidence with the weight variability data that we can go back to the agencies to tell them that they should be continued for a while until they are really able to maintain that weight loss, or, in some way impact the policies?
For sure, the NHS from UK is stopping the reimbursement after 2 years for semaglutide. But because the position is that semaglutide for this agency does not work after 2 years, particularly when the steady state is reached. But also there is a recent survey from the States where you see that only 1 on 4 is continuing the treatment after 2 years. So this opened really a huge problem, because what next? Meaning that people are now using, widely using, there is a shortage of these drugs because the companies are unable to follow the needs of the people. But at the end, nobody is paying attention what to do when these drugs are stopped. And particularly, the issue is that very often the drug is stopped for the side effect, because honestly, we cannot forget that the side effects of these drugs are nausea, vomiting, and that these drugs, they work at the central nervous system mainly. So there is something that's changing in your brain, and then the regain of the weight is not only because there is not the drug, but very often there is a rebound effect when the drug is stopped. So until now, we have paid a lot of attention to the possibility to have a very good effect in lowering weight, but now it's time, in my opinion, to be careful and to understand what next. Because I think that these drugs cannot, even some colleagues, they think that is possible. I do not think that they can be continued for life, honestly.
Sure. And it also, it definitely brings us back to the question that are we getting it all wrong by just measuring the BMI as a marker of obesity? And should we really look at, just the adipose markers or, look at the visceral fat or some more meaningful marker rather than just BMI?
Yeah, because also it's has been shown that the regaining weight, when you lose weight using the drugs, there is a reduction in both body fat, but also the muscles. But the regain is only in terms of fat.
Fat.
So it's even worse.
Purvi, can I ask Dr.
Yes, please.
Mangesh a question, because he spoke to us in Spain about cytopenia, what is that called, muscle loss in weight loss. So Dr. Mangesh, please.
Yes. Yeah. So, in fact, that's what exactly Dr. Antonio was pointing out. This is a big challenge as far as the Indian subcontinent is concerned. And also, I would like to add, Purvi, that one of the marker for adiposity is now the simple marker that we can use is usually steatohepatosis or an ectopic fat deposition in the different organs. So apart from the adipose, I would say adiposopathy, it's also, as you rightly pointed out, the signs of inflammation or the markers of inflammation along with the overweight and obesity are one of the prime deciders. And as far as sarcopenia is concerned, in fact, that is a short marker for so many things. And especially when it comes to the metabolic disruption, inflammation, high insulin resistance in what we call it as typically now, as Dr. Yagnik even in this EASD talk told us about it. Now this is the time to move away from the terminology of now thin fat Indians. Now we have come to the sure sarcopenic Indians. They have very high inflammation and very high amount of sarcopenia. So whenever you are assessing your patients on these parameters, you have to be very careful. And you need to use all your tools to not only try to evaluate, but also to manage them properly and find out the best methodologies to really treat them. So that is my take on this.
Couldn't agree more, sir.
Yes.
Dr. Ram, can I ask you a question to Dr. Julia?
Yes,
Yes.
sir.
Yeah. Julia, we are discussing about overweight, obesity, and also weight variability. So in the management of type 1 diabetes, until very recently we were using, and we were having some clinical trials using multiple hormones in the insulin pumps, using amylin, using pramlin. I remember even using one of the GLP-1s. And recently I read about a clinical trial data where there was no differences between the two. So do you foresee in future only using insulin, or do you foresee using something else other than insulin in the AID systems, considering the weight gain in type 1 diabetes as well?
That's a very important and very good question. And fortunately, some companies have now moved again in the direction of looking into weight gain of type 1 diabetes, because like some of the programs by Novo and others were stopped in the past. But I think they now observe that there is a need also to have specific trials, because we see from real world data that adjunct use, for example, also from GLP-1 receptor agonists is beneficial in type 1 diabetes with weight issues and high insulin doses. And yeah, so there is hope that we will go into that direction. And I guess not only from the weight gain and from the insulin dose side, but also from the expected benefits when we think about the cardiovascular and kidney diseases. So I think it's high time that we do not look only into glucose lowering drugs, but also into drugs that have more polypotent effects, again, in type 1 as well.
Can I ask one question, madam, about the bionic pancreas? Bionic, they use glucagon and insulin. What are the advantages of that over the conventional pumps?
So what we have seen, but I have to admit, I have not had it in my hands yet, so it's not in my country available. The advantage is that it obviously needs or reduces the risk of hypoglycemia. but we do not see a real big benefit in time in range. So I think it's maybe some advantages that we have. I don't know about the costs. I don't know about the costs then for the glucagon, if that could be maybe a challenge for another person. So for me personally, if I have to invest in a second drug, I would rather go for a GLP-1 rather than a glucagon at present. So I think the current systems are quite good in managing glucose control, but we overlook issues that you have raised before, weight and so on.
Yes, madam. I heard a paper in EASD where they used once a week this semaglutide and insulin, and they found out weight loss is better or weight gain is less with that.
Yeah.
That is
so we do that also. Exactly. So you just inject it, and we do have some people with type 1 diabetes with high insulin doses above 2 units per kilogram body weight or BMI of 30, where we also start GLP-1 in type 1 diabetes in routine care. And it's funded even in my country by insurance companies in that case.
Oh, thank you, thank you.
Can I ask one more question, sir? Madam, what will be the next after this closed loop? What will happen next? Now they say it's hybrid closed loop. Okay, what will be next after closing the loop?
So I think we are also on the way to better beta cell protection and preservation. So if we move out of the field of technology, if we stay in the field of technology, it's going to be probably the add-on of ketone monitors that we can see, and maybe multi-monitoring. So many companies now think of what else can they monitor next to glucose. And the ketones, of course, have the advantage that you can hopefully detect the pump occlusion, specifically also the risk of ketoacidosis in the ones who use adjunct therapies with SGLT2 inhibitors. So I think that's maybe an interesting field for the future.
Thank you very much. Dr. Jodhdev, you can ask.
No, I'm okay, I'm okay. I think it is 9:30, so that's it.
Yeah.
Yeah.
And, I want to ask Dr. Antonio. Is there?
Okay, Antonio. Okay, okay. Yeah.
Is not there. Okay. Anyway, if there are some more questions to be asked, you're most welcome.
Actually,
Dr. Antonio.
I have a very small question. It's again a repetition because from Antonio's lecture, what I understood is even for the GLP-1 based therapies, when there is a robust weight reduction followed by discontinuation of the drug, there's a weight gain. So there again, the possibilities of a weight variability is more with all these newer drugs. So it is slightly scary to listen because it is glucose variability and lipid variability, and now it is weight variability. So we have to gather more data, and we need to have precise answers on how much of this variability is clinically significant. As you said, whether it is 2 kilogram or whether it is 2% or 5% or 10%, how much of this will be having a significant impact on the cardiorenal outcomes?
Thank you, sir.
Yeah.
This is an open question because at the moment, all the data, including our data on this topic, are looking at the standard deviation from the mean. And it's not clear. So higher is the variability, higher is the standard deviation from the mean. So we need to have more details in this context, because as I told before, it's the same to go from 70 to 72, or from 90 to 92. It's not clear. So as well, it's also the same if you from 70 you go to 80, or from 80 you go to 100. So it's open question. At the moment, this is not well defined, but the number of papers on this topic are increasing a lot. Also, we have a paper in revision again with the Swedish registry, that this is unfortunately is also true for type 1 diabetes. And so you see that type 1 diabetes is some that the patients are doing, but probably also the doctors are doing in terms of using too much insulin. So this story is just starting, and it's really interesting to see that the story started more than 30 years ago and then stopped, because the paper in New England is of the beginning of the 90s. But until the recent years, nobody was paying attention. Now, there are several papers coming, because of course, I show only a synthesis of what is available on this topic, of course. But many, many papers are confirming this. So I think that really it's an open question, but particularly it's an open question what to do, because it's not just very, very simple. Say, okay, keep the weight. Not very simple. You know, we know, or us, we know how difficult it is, particularly for countries like Italy and India, where the carbohydrates are really the base of the diet.
As Dr.
Thank you,
Benji
sir.
said, it is a very, very exciting topic. And with the new triple agonist and even the tetra agonist, the weight loss is going to be more than 25 or even 30%. And hence this topic is going to be in future very, very relevant. Thank you very much, Dr. Shariello. Thank you.
Sir, what about bariatric surgery and the weight variability impact of bariatric surgery?
But there is not so much weight variability in the bariatric surgery by definition, because the quantity of energies, of calories is dramatically reduced. So this is, but we have data about the glucose variability that also is dangerous, because you know this is not a field yet explored.
Good, very exciting field.
Okay. Sir, Dr. Antonio, I was in Portugal and I asked what is the common name. They said it's your name, Antonio. So I hope you're from Portugal. Anyway, it's very interesting. And Dr. Mangeshkar, do you want to ask any more questions? And Doctor? Okay. Can we close?
Amit is there.
Yeah. Can we close?
Dr. Ramkumar, first of all, thank you for your wonderful motivation. Dr. Julia, Dr. Antonio, thank you for bringing the updates from the EASD. And both the topics are very, very relevant, whether it is the weight variability or the use of AID. Weight variability is actually giving us more responsibility, that it is not just the weight loss which we should look for. We should also look for the sustainability of the weight loss, because only then the real world benefit in the cardiovascular mortality will be seen. And this is what the Dr. Antonio is trying to convey in his talks. And Dr. Julia Madar, as usual, she has brought the updates on the AIDs and the latest at how, and she covered almost each and every aspect of the AID. And with this, and the Dr. Purvi Chawla, Dr. Jyoti Dev, Dr. Ramkumar, Dr. Mangesh Tivaskar, thank you for having a very insightful discussion. I hope all the attendees today must have benefit. And I can see Dr. Bansi Sabu is ready with more updates regarding today's program. So I hand it back to Dr. Bansi Sabu for making the final remarks.
It's not to hand over. You are giving final vote of thanks. I just come.
I was
goodbye and good night.
Thank you, sir, for having us.
Thank
I
you
was
very
just
much for this
waiting for updates for today's registration from your side. I thought you will give that.
I want to tell one thing. In our
Good
scriptures,
night from India, Antonio and Julia, because they have still the evening there, but from India it is good night time. It's 9 p.m. 9:30. And once again, thank you, Antonio and Julia, for your very wonderful talk, and thank you for coming.
Thank you everyone.
It was a pleasure. Thank you.
And we see you tomorrow again for the 4th day of the learning from the EASD, where we will bring more updates to you. So
just
do
inform that we get every day around 4,000 delegates who registered, but roughly around 1,400 to 1,500 doctors, they listen. And those who are registered, they will listen this video recording maybe later on. But this is what roughly we are getting every day. So we are very happy that, many people across the country, they are listening it. And everyone can't come to EASD. And this is one updates which we are giving them from Diabetes India. So thanking you all the speakers and all the panelists for this wonderful program. Thank you, Amit. Once again, Diabetes India.
Thank you.
I want to end with one
Good
saying,
evening.
whether it is diabetes control or weight loss, laughter will help you. So keep laughing. Laughter has proven good for weight control and diabetes control. Keep laughing. Thank you very much.
Thank you.
Bye-bye. Good evening.
Bye.
Bye.